and young adults, HIV and mental health in Tanzania and globally, what the Sauti Vijana intervention entails, how is it delivered, what were the results from the Sauti Vijana randomized trial, but then also how were the observation on other measures that were made during the Sauti Vijana randomized trial. So I would love to first start with the media team and not from the audience. So please hold your phones. We will not allow, and that is for both presentation and
yeah, thank you very much, Doc. Thank you very much, Doc. So that you can see what we have been working for the past almost 10 years with the adolescent health in improving adolescent mental health and why we have done this one. Yeah, we all know that HIV is still a challenge, and over 40 million people are living with HIV worldwide. Unfortunately, adolescents have not yet been spared. So age 15 to 24 years account for about 8% of people living with HIV. But in the female population, we see it goes up to 28% of new infection annually, and 6% of all deaths due to AIDS are accounted by adolescent team. So in Tanzania, it's approximately 1.8 million people living with HIV, and among this, there is estimated about 114,000 of people living with HIV being youth and young adults and adolescents aged 15 to 24 years, which account for approximately 1% of this. But looking at our Tanzania HIV indicator survey, you see that 68% of all youth living with HIV, they are aware of their HIV status. That means there is 32 who doesn't know if they're infected. And among these 68%, only 67% are receiving ART treatment, and in addition to this, only 57% have their viral load measured, and or they have viral load suppression. So this is a potential group, and when you look at the indicator compared to the 95 strategy, that means we are behind. And also we have to understand that HIV incidence in adolescents trigger a cascade of other challenges, including mental health, behavioral, and also cognitive challenges that may affect actually HIV prevention, treatment, as well as adherence to treatment, as a result impact the long-term management and outcome which is expected. And globally, looking at the meta-analysis which was done, it shows that among youth living with HIV, mental health, including depression, account for about 28%, anxiety 22%, but also post-traumatic stress disorders around 12%. And this becomes more for HIV infected compared to non-infected individuals. And when you look at sub-Saharan Africa, the review which has been done shows like around 25% of HIV patients are screened for psychotic disorders, and 30 to 50% experiences emotional or behavioral difficulties, which actually impact significantly into their well-being as well as daily survivals. So looking at the situation of mental health and HIV in Tanzania, we can see that study has shown around 12 to 41% of youth living with HIV has symptoms of depression, suicidal thoughts, which also occurs to around 31%, but also stigma driven, You know, being HIV, it causes a lot of internalized as well as externalizing stigma, low hope, and we know also these are also impacted with the low human resources and the mental health specialists to support care, but also understanding where they could turn into care whenever it is needed. And the current Tanzania new National Mental Health and Psychosocial Support Strategy prioritize adolescent well-being, this including the issues related to mental health as its core objective in integrating mental health services in adolescent care. This including in reproductive and child health, but also in youth services, to make sure that by 2028 that these services are integrated. So efforts are needed from both of us to make sure that these are integrated. So then why did we wanted, or why it's important to have the Sauti ya Vijana, or Voice of Youth intervention? In abbreviation we call it SYV. We had to do SYV because we know adolescent, adults and the youth are not spared with HIV. From the data I have shown that there is higher prevalence of HIV, but also poor outcome. We have seen viral load suppression around 57%, but also poor quality of life, especially when they are impacted with also the issues related to mental health. So it was quite very important for us, first of all, to understand mental health distress in this population, but also to realize what are the obstacles which face this group to accessing care by learning through the knowledge and communication barriers which exist, but also what kind of services which they can access.
HIV as well as mental health outcomes. Adolescent did a pilot and co-created SYV with youth who live with HIV to try to address the challenges they were facing that were keeping them from taking their medicine. A little more about them. Two of those are with caregivers. We learned adolescents don't sort of live in their own bubble. They have families and screening currently. And 15 to 19 and 20 to 24 was our target. And they were gender concordant. So girls met in groups with girls, with female group leaders, same for boys and male group leaders. All the youth were fully aware of their status, and they had been prescribed antiretroviral therapy for at least 6 months. This was to allow them to have time to suppress their virus if they were going to. And they were committed to attend sessions if they were randomized to the intervention arm. We excluded youth who had active psychosis or cognitive disability that would prevent them from really understanding the study, prevent them from disclosing or being able to actively engage in the sessions. And then the peer group leaders were chosen really from their local sites. They were 23 to 29 years of age with a lived experience. They exhibited good adherence and confidence to stand up and teach peers. Our primary outcome was viral load, and so we defined viral suppression as less than 400 copies per ml. And then we looked at self-reported adherence using a validated 3-question measure. It's a pretty short measure, and the scale is 0 to 100. Training and supervision is a really, really key part of SYV. We're asking a lot of peer leaders in engaging with this peer group that has a lot of mental health challenges, and so they needed to have a supervisor to ask what to do with some of the youth who really had some challenges beyond the scope of SYV. So in training, we had a psychiatrist, a psychologist, and a pediatric infectious diseases specialist. We all helped co-create the intervention. As I said, we piloted in Moshi, and so that was sort of the expert site. And our team from Moshi brought everyone into the Moshi area, and we all trained the field sites. So 6 expert group leaders from the pilot trained 25 new group leaders across the 4 sites and 4 new supervisors. But supervision didn't end there with the 2 weeks. Once everyone went back to their respective sites, we continued with weekly supervision. Youth leaders would practice the content they were going to deliver on Saturday. Intervention happened on Saturday mornings to allow youth who go to school to have time to come in. And then one group leader would take notes and observe what's going on, mark fidelity. Two group leaders would facilitate the intervention, and then the next week they would send the fidelity and session notes and discuss with the supervisor how the youth were doing, if there were any challenges. So very briefly, what is SYV? So again, it's 10 group sessions. The first session's a lot about HIV knowledge. Youth describe their worries, their fears, and then we try to bring them some coping strategies of how to handle what's happening. So we really leaned into cognitive behavioral therapy, or how your thoughts influence your feelings and your behaviors. We learned from youth that when they learned about their HIV status, it was really traumatic, and they hadn't really talked about it. And so we took 3 sessions to really help them unpack what happened, what was happening before, when they learned they live with HIV, what happened after, and how they're doing now. You'll hear more about this in a talk coming up. And then we talked about circles of support. So a lot of youth would come and we'd say, you know, who do you go to when you have emotional distress? And they wouldn't really have an answer. And so we really asked them to think about people in their circles and who do they trust, who can they go to? Because we all have things that happen in life and we need someone to lean on. And so we wanted them to be able to identify who those people are. We talk about stigma. With youth, this was described as a snake. So internalized stigma can strangle you. Your thoughts, negative, you know, I'm not as good as this person because I have HIV, or I'm not going to live long enough to even bother going to school because I have HIV. We really tried to use CBT to help them rethink and recognize those negative thoughts. If they think they're just going to die, they probably feel pretty hopeless, and so why behave, why bother taking medicine? But if we can help them rewrite that narrative that I can take meds and live just as long, I can achieve my dreams, then they feel hopeful, and that leads to better behavior in the sense of, you know, having a reason to take their medicine. And then we talk about disclosure to other people, and youth describe this as like living in a lock or carrying this burden of a secret. And so we try to empower them that they have the key. So it's up to them. And whenever they're ready and they find someone they want to share that secret with, they can do that. We give them steps that we'll talk about later. But if they do give that key, it doesn't always go perfect, and we talk about that. But when it goes pretty well, their lock is unlocked, and they talk about kind of this weight being lifted and feeling free, getting support for taking meds and other things in life. And then finally, we talk about values and moving on positively. So, for instance, if their value is health, we talk about it's their choice, right? Youth don't want to be told what to do. They don't need our advice. It's really coaching them and making their own good decisions. And so if their value is health, they get to choose every day whether or not to take medicine. And we, you know, just talk them through why maybe taking it is a good idea. So that's kind of in a nutshell what SYV is. So to our results, we enrolled 690 youth across the 4 sites. You can see enrollment is pretty spread evenly. 349 were randomized to SYV, 341 to standard of care. These are the baseline demographics. So the average age was 17 and a half. Half were female. Most were perinatally acquired HIV, so 81%. Very few reported alcohol or drug use, and most of them are receiving pretty potent antiretroviral therapy with TLD or tenofovir, lamivudine, and dolutegravir. Attendance to the sessions per protocol was quite good, around 90%, and this was true across sites and for both genders. And we put this quote here: I liked all the sessions. I learned because each one is beneficial. I also love the leaders who taught me. They've taught me with love and without anger. Even when participants arrived late to the sessions, they advised and addressed this in a very loving way. So this intervention only works if the group leaders are good, if they're learning from the sessions, if they're having fun in the sessions. And it's really a tribute, this quote, to how great I think our group leaders really did in delivering the session content. So our primary outcome was viral load. Our cutoff was 400 copies, And you can see at baseline, kids were doing really great. Dolutegravir had rolled out, and 86% in SYV and 88% in standard of care were suppressed. It's hard to move the needle to perfect. We were powered at a 10% change, which is basically perfect. And so though we didn't quite meet our primary outcome, we did meet a lot of other really important outcomes. We also looked at viral load cutoffs of less than 50. This is a much more stringent cutoff that the government is starting to use. And we did go up by a few percentage points, but again, we weren't able to meet a statistically significant measure here. Same for adherence. Youth were reporting, self-report that they were taking their medicine pretty well. They weren't saying it was perfect, but dolutegravir is very forgiving. And so I think these are pretty honest answers. We didn't change adherence all that much, and suppression was quite good to start with. And then this is a regression analysis that just shows there was no statistical difference, unfortunately, between arms for suppression or adherence. And so at baseline, for those who enrolled, almost 90% were already suppressed and had good adherence, making it difficult again to show a change. But evaluating the secondary outcomes that Dr. Gertrude and others will tell you about, I think we did move the needle quite well. And I think we also, it'll be interesting to see over time, 12 months, 18 months, do we start to see a split? Do the SYV group over time do better? So I'll welcome Dr. Gertrude up, and she'll tell you about our mental health outcomes.
Asante sana, Dorothy. So I'm Gertrude from Ifakara, pediatrician and research scientist, and I'll take you through the mental health outcomes that we looked at in the SYV trial. And so, as it has already been stated by previous speakers, and it has been reported that mental health account for 13% of global burden of disease among adolescents, and many a times the onset of mental illnesses is during adolescence, only that many of them do not get diagnosed during that age group, hence starting to get treatment during adulthood, but it's something that really emerges during this critical developmental period of adolescence. And depression and anxiety have been commonly cited to be the commonest. And a recently produced systematic review that looked at specifically on adolescent and young adults living with HIV also cited depression, anxiety, and post-traumatic stress as commonest mental illnesses in this population. So as we know, adolescence is a critical developmental stage, moving from childhood clinical care setting, childhood. If you look, of care that under standard of HIV, months later, the proportions remained higher, scoring above 5 in the standard of care and 2.7 scoring above 10 in the standard of care arm. Anxiety, as we have seen for depression, there was a decline over time in both arms, but still proportions of those who presented with significant symptoms that were higher among those in the standard of care as compared to those in the SYV arm. 12% scored above 5 at baseline in the standard of care, and 2.1 scored above 10, in the standard of care arm. For both of the arms, we really appreciate that the symptoms or the proportions went significantly down, but there was no significant differences between the arms over time. And those who present with composite, both depression and anxiety, or depression or anxiety scoring at more than 10 in both PHQ-9 and GAD-7, proportion also declined in both arms, starting from 5% to 2.7 in the standard of care arm, and 3.7 to 1.3 in the SYV arm. And just to remember that what the standard of care arm got, as Dorothy explained, was the referral and management for those that had significant symptoms, something that by then was already not in the routine care practice. For stigma score, the mean score for stigma was higher at baseline for both of the arms. The difference between the arms in the mean score was 0.3, both at baseline and 6 months later, but we see a slight decline from around an average of 26 mean score at baseline to 24 mean score at 6 months later. So what have we learned in this, looking at the mental health measure that I've presented, is that the symptoms of mild and severe forms of both anxiety and depression were higher, slightly higher at baseline as compared to 6 months later, and the decline or the proportions remained slightly higher in the standard of care as compared to the SOAV arm. But then observing the decline in both the arms make us appreciate the role of screening and referral for those adolescents that I need. For example, as we say, mental health is, the burden is big among adolescents, but not all the 690 will need to be a counselor, to see a counselor. Of those that see a counselor, not all that will need to be referred to a psychiatrist. But if you manage to identify those who need and provide them that care, it can really address mental challenges that they go through. And also coping, self-efficacy skills increased more in SOV than the standard of care, although it wasn't statistically significant. But these are very important attributes as we strengthen adolescents as they transition from adolescence period to a more independent adulthood stage. So with that, I welcome my colleague who will tell you about exposure to adverse childhood event as it was measured during the trial. Karibu.
Yes, thank you so much, Dr. Gertrude. My name is Nasrat Fadhili. I'm a medical doctor, but I've also completed my master's training in clinical psychology at the University of Nairobi. I'm a D43 trainee, and the PA of the SYV team have been mentoring me. So we went further to study more about the mental distress among this population, and I'm here to present the finding of our research titled as Association Between Adverse Childhood Experiences and Symptoms of Mental Distress Among Adolescents and Young Adults with HIV in Tanzania. Okay, so by introduction, adverse childhood experiences, adolescents and young adults living with HIV are facing higher number of adverse childhood experiences, and this include multiple forms of abuse, neglect, and household dysfunction. And this is of a particular concern for this population because evidence suggests that having adverse childhood experience score of 4 or more is associated with increased morbidity later in life. So this is important to acknowledge and mitigate the impact of adverse childhood experiences, because if not, it may hinder adherence to antiretroviral treatment, may compromise mental health, and may also affect the overall resilience of this population. So the focus of our study was now to determine the association between adverse childhood experiences and symptoms of mental distress among adolescents and young adults living with HIV. So this was our research question. So basically we used baseline data from this 5V trial, as reported that we recruited 690 participants from 4 regions of Tanzania. In our study, we employed different tools, one being the structured questionnaire, which we are able to capture the demographic characteristics. We also screened for depression by using PHQ-9 and anxiety by using GAD-7. But also we were able to identify the mental health distress by having a PHQ-9 score of above 10 and GAD-7 above 10, which marked having moderate to severe level of depression and anxiety. So we were able to screen the adverse childhood experiences by using the recommended WHO Adverse Childhood Experience International Questionnaire, which measure the 13 types of adverse childhood experiences. And this tool is, the question is set in a way that we are able to identify if a participant has ever experienced an adversity, but also the questions are set in a way that they are able to identify the frequency, how frequent this child has experienced an adversity. So for example, one question which asks about the physical abuse, it is written as, did a parent or guardian spank, kick, punch, or beat you up? So the response are either never, rarely, sometimes, most of the time, or always. So at this point, we are able to identify if a person has ever experienced an adversity, but also we went further to see how frequent it was. So at this point, we are able to do a binary score and a frequent score. And in both score, a score of 0 signify not having an adversity, and a score of 1 signify having an adversity. But now what is the difference? The binary score only capture those who answered rarely or more, and the frequent score only capture those who responded most of the time or always. So we did a data analysis by using a guidance for analysis of ACE International Questionnaire, but also we did the linear and modified. So these were our participant demographic characteristics. The mean age of our participant was 17.5, reported to have at least education, secondary education level, and the HIV-related stigma was high with a mean score of 26.3, but sadly 65% of our participants reported not to have reliable social support network. So now we are going to see the results. Up to here in the table, you can be able to appreciate the 13 types of adverse childhood experiences. And I would like us to focus on the commonly reported adversity, which in our study was emotional neglect, reported by 89% of our participants, and 69% reported to have experienced emotional neglect most of the time. But also community violence was common, with about 87% of our participants reported to have it, and 79% of our participants reported to have one or no parent, or their parent have separated or divorced. We went further to see the number of adverse childhood experiences reported, and here we can see the mean score in the binary score was 4.7, and in the frequent score it was 3.0. So what is important to note here, we found that 64% of our participants reported to have experienced 4 or more adverse childhood experiences, and 31% has reported to have experienced these experiences most of the time. So how is this a concern? As we can see here, having the more you are having adverse childhood experiences, the more you are likely to report mental health difficulties. As we can see here, participants who had higher ACE score reported to have mental health difficulties as compared to those who had no mental health difficulties. So we went further to do a regression analysis, and these are our results. So in both the linear regression and modified regression model, the association between adverse childhood experiences and symptoms of mental distress was statistically significant, with having a high adverse childhood experiences being associated with having symptoms of mental distress. So we can see here in the linear regression results, for every 1 unit increase in ACE score, there was an increase in symptoms of depression and anxiety. And this is to note that for those who were having adverse childhood experiences, they were having 1.51 times higher risk of having moderate to severe symptoms of depression, and 1.7 times higher risk of having moderate to severe symptoms of anxiety. So in conclusion, our findings show that adolescents and young adults living with HIV they're having common adverse childhood experiences, and these adverse childhood experiences are associated with symptoms of mental distress that include symptoms of depression and anxiety. And what that this tells us means if now we address or we prevent occurrence of adverse childhood experiences, then we can reduce the risk of these mental disorders from occurring. So this signifies the importance of having psychosocial support system among this population, but also the importance of being able to address the broader aspect of social determinant of health among this population. Thank you for listening. I would like to welcome Dr. Lillian to talk about the HIV knowledge.
Thank you, Nasrat. My name is Dr. Lillian Komba from Bella Foundation, Tanzania, and the site PI for the Mbeya site. I'll take you through HIV knowledge among youth in the Sauti Vijana program. So young people 10 to 24 years of age make up to more than 60% of the Tanzanian population and are vulnerable to sexually transmitted infections, including HIV and unintended pregnancies. Levels of comprehensive HIV knowledge range from 25 to 46% in sub-Saharan Africa. Strengthening HIV knowledge in this age group is essential for improving prevention and treatment of HIV, reducing stigma, and empowering young people to make informed, healthy decisions. So we had two research questions. What is the level of HIV knowledge among adolescent and young adults with HIV enrolled in the SIV compared to the national statistics? And the second one, does the participation in Sauti Vijana improve HIV knowledge among adolescent and young adults with HIV? Compare HIV KQ18 evaluated HIV knowledge across 3 domains. Transmission myths, prevention strategized as correct if the correct answer was chosen. Incorrect included wrong answers and I don't know. Overall scores were determined by the percentage of correct responses from range of 0 to 100. A subset of questions were mapped to the UNFPA knowledge questionnaire to compare a survey respondents' knowledge to a national sample based on all 4 questions answered correctly. Descriptive statistics were used to evaluate participants' knowledge at baseline and at 6 months. So here is the UNFPA questions used. There are a total of 5 questions, and the average score was 37% of people who answered all the questions correctly. So in our SYV, we used the HIV knowledge questionnaire with 18 questions, and we chose only 4 questions which corresponded with the UNFPA questionnaire. So the score here was about 27% for all people who answered all the 4 questions correctly. So you can see there's a difference between the 2 SYV questionnaire and the UNFPA questionnaire, but the next slide will let us know as we peruse the individual questions as they responded to them. So here are the 4 questions from the SYV questionnaire and the response rate. As we see in question number 1, which was more of the myth, if a person can get HIV through a glass of water, and we see in question number 2 and number 4, they are also scored at an average of 70%, which was fair. And we can see the question number 3, this is a question about the female condom that can help decrease the women's chance of getting HIV. As we can see here, it was only less than 50% answered it correctly, but alarmingly that 40% did not know the answer to this. So this can be, we predict that these results were impacted the overall performance of the questionnaire between the UNFPA and SYV questions from 37% to 27%, as the female condom may be very scarce at our health facilities, and most adolescents did not know that maybe it is used for HIV prevention. They are not aware of that, and this may impact on their decision on the informed choices of using a condom as a preventive tool for HIV. So when we come to see the results across arms, HIV knowledge on the 4 UNFP equivalent questions improved more in the SYV compared to the enhanced standard of care. So you can see in the SOV arm, at baseline they scored 26%, and at 6 months it was 48%, while overall 27%, the knowledge was 27% at baseline and 40% at 6 months. So if we see the change in percentage correct of all HIV, KQ, and T knowledge questions, we can see that there was a statistically significant improvement in HIV knowledge in the SYV arm as compared to the enhanced standard of care. So you can see at the baseline standard of care, they had an average score of 60%, while at 6 months it raised to 68%. And this estimated mean difference adjusted for covariance, it was 5.66 higher at 6 months compared to the baseline for the SYV. So in conclusion, HIV knowledge significantly improved in the SYV arm compared to the enhanced standard of care at 6 months. Despite this gain, knowledge gaps persist and interventions need to continually address HIV knowledge to improve HIV prevention and reduce HIV-related stigma. The gains seen in the SYV intervention arm support the importance of scaling SYV towards providing comprehensive, gender-sensitive, and contextually adapted HIV education in Tanzania. Thank you for listening, and may I welcome our next colleague, Susan, for the next presentation. Thank you.
Thank you, Dr. Riri. Good afternoon. Yes. So my name is Susan Gayoma. I'm a professional counselor, and I'm currently taking my master's in social work here at Institute of Social Work, Adolescent. And I'll take you through empowering HIV acceptance and disclosure through Sauti Vijana. So disclosure of one's HIV status is very important, but it is a very sensitive process, especially to adolescents and young adults who are living with HIV. And how one learns the HIV diagnosis can be significantly associated with mental health challenges and stigma, especially if they figure it out without being formally told, either by a care professional or family member. So decisions about if, when, and to whom to disclose are influenced by cultural norms and stigma, often accompanied by fear of rejections or violence. And the disclosure can impact negatively or positively mental health, adherence to ART, and violence suppression. So in SYV, we used questionnaires, the baseline questionnaire, where we asked how much participants learned their diagnosis and if they have ever purposely or verbally disclosed their HIV status to another person. But we also used a repeated questionnaire at baseline and after 6 months, ask if these participants now are sexually active and disclose to their partner. And these summary statistics were used to describe the prevalence of self-disclosure. But also, we had focus group discussion, and the thematic content analysis of this focus group discussion was used to summarize the experience of disclosure to these young adults who were living with HIV. Disclosure is a topic woven throughout the SYV, and as the SYV participants had time to share the disclosure narrative and their stories, like what happened after they learned that they have HIV, what happened before, and what happened after, and what is happening now. So they shared this to their peer youth leaders and also with their group, and also with their caregivers. Though caregivers knew about it, but they had time to share with them. So they also learned about decisions about disclosing one's HIV status. And these youth, they discussed the reasons for and against disclosure, emphasizing the importance of protecting themselves and sexual partners. As you can see in the picture, the first picture shows that they were locked with their secrecy, but when they were empowered with skills on how to disclose, then it gave them as a key for them to disclose. And we had 5 steps for effective disclosure, including building trust and prepare for reactions, and also the role play scenarios which allow these youth to practice to disclose to others. And coming to the baseline demographics, as we can see there, those who had disclosed were likely to be aged and more likely to be female, biological suppressed, sexual active, and currently married. So we can see as the age 19.4, and in sex as female we are 67%, biological suppression 91%, sexual active 70%, and currently married 13%. So among the 690 participants, the 84% reported that their HIV status was intentionally disclosed to them. And this disclosure was primarily by a family member with 51%, or a healthcare provider with 43%. And few youth, 141, reported ever intentionally disclosing their HIV status to someone else at baseline. And among the 248 participants reporting to be sexual active, while 104 reported disclosing to their sexual partner at baseline. Now, coming to change in disclosure to sexual partner, as we can see at baseline, 38% of participants reported disclosure to their sexual partner. And at 6 months, 44% reported disclosure to their sexual partner. And we can see this at SYV arm, was seen as higher, that many of them were disclosing, and this shows that SYV was very important and has helped this use. But in EN's standard of care, the percent you can see at baseline was 46, and after 6 months was 42. The disclosed went down because after 6 months, due to some youth who had disclosed not attending the 6 months visit. So they were different. For those who came at baseline, and after 6 months, others were missing the visit, and other youths reporting new sexual partners whom they did not disclose when they were at baseline. So coming to the qualitative results, we can see the common themes for not disclosing, included fear of rejection and being isolated at the main barriers. And participants reported in focus group discussion that the disclosure session gave them practical skills and confidence to disclose their HIV status safely. Also, participants described learning how to build trust, assess attitudes, prepare to have conversation, as increased their readiness and the willingness to disclose. So here is the quote from one of the participants, a male from Ifakara, who said, "I learned about being open and keep things private. Before joining the group, I was not open with my relatives. I used to hide things, even taking my medication. I was afraid that if someone saw me taking medicine, they might spread the news about my status. But after joining the group, I learned that being open can help because you can choose to confide in a specific person or everyone. This helped me a lot." Yeah, so the WHO has put forward a first ever guideline, the disclosure guideline, and as SYV, we are very proud that we are among the featured the disclosure inclusive intervention. And as I can say it as a counselor, we have seen that through narrative disclosure and these steps to disclose has helped a lot these young adults to accept themselves. And as we know, disclosure is challenging, but through learning, through teaching them and training, we can see the SYV participants who are there now are able to be free and well to disclose. I can conclude by saying few adolescents and young adults living with HIV have intentionally disclosed their status to others. And peer-led intervention like us, SYV, can help these adolescents and young adults accept their status and safely practice steps of disclosure. Thank you very much, as I welcome Fortunata to continue.
Hello everyone, I'm Fortunata Nasua, a Community Development Officer, and in Sauti Vijana I worked as a qualitative evaluation personnel. I'll take you through the provider and government input on acceptability, appropriateness and feasibility of the Sauti Vijana mental health intervention for adolescents and young adults living with HIV in Tanzania. So evidence-based interventions sometimes do not really reach people who need them due to implementation barriers. The aim of this presentation is to report on the SYV from the provider and government stakeholder perspective on the implementation outcomes. We'll be having 4 outcomes out of this, which is acceptability, is the perception or among stakeholders that Sauti Vijana is agreeable or satisfactory. Appropriateness, the perceived fit of Sauti Vijana to address a certain problem. Feasibility, the extent to which Sauti Vijana can successfully be carried out at a given setting. And sustainability, the extent to which Sauti Vijana is maintained or institutionalized within a service setting, ongoing in a stop of operation. So the methods used, it was the in-depth interviews which were conducted to clinical providers who care for the youth at adolescents at the HIV clinics in all 4 trial sites, and who had a role as in the project, and this took place in January to June 2024. For the government officials, which we describe as the outer setting, were engaged in some of the SYV Sauti Vijana stakeholder meetings at various times. The interviews were conducted in person by a trained qualitative researcher, audio recorded and transcribed. At the end of each interview, a validated implementation outcome questionnaire was conducted, and the responses were averaged to provide a mean and standard deviation using Excel. So this is the example of the questions from and 40% were medical doctors or counselors. For the outer settings, they were both male and medical doctors. So the results from the implementation outcome questionnaire, for the providers, they all strongly agreed that Sauti Vijana is acceptable, appropriate, and feasible at the average score of 4.5 and above. And for the outer setting, which is the government officials, they also completely agree, but they were uncertain or unsure of the appropriateness and feasibility of the intervention due to the timing and the cost for the intervention. We had many courts for the intervention, but now we are talking about the qualitative part, which we were having enough courts about acceptability, appropriateness, and feasibility and sustainability of the project. So this is one from the clinical provider who was talking about the confidentiality which increased to the youth, the adherence of drugs, ART, and also the positive change for their future. And it says the way the youth open up during the sessions and they talk about the importance of the sessions and they see the sessions helps in their drug adherence, but also to have a positive attitude in all what they do in life. On appropriateness, we asked the clinical providers, what does the Sauti ya Vijana intervention offer, if any, that the clinic or the health center does not offer to the youth living with HIV? So to show appropriateness, they said, we don't get a chance to look at the life of the surrounding youth. Mental health is something that is much forgotten, and it's something we need to invest in and be in the package of care to youth living with HIV. So this one is one of the good quotes. As I said, that the government officials were not sure about the appropriateness and feasibility of the intervention. The first one said the acceptability, it's about Sauti ya Vijana meets my approval. One of the this government official responded that I like it and I recommend it 100%. And the appropriateness, Sauti ya Vijana seems suitable. That was the question. But completely, our workforce lacks the necessary skill set. That is the gap. For the feasibility, there was a statement saying Sauti ya Vijana seems implementable. And he also added by saying, but it is not easy. It requires extensive training. It is not something you can just rule out without preparation. So that is a quote from one of the government officials. On sustainability, we asked, do you think Sauti ya Vijana intervention should be incorporated in clinics or health centers that provide services to people living with HIV? This is one of the quotes that I'm reading from a clinical provider. Yes, but there is nothing that can be received well without being blessed or being supported and accepted by the government and Ministry of Health. They have the authority to assess the need and that it will bring a positive change. From one of the government officials, they also encouraged about sustainability and talked about it. A good intervention with positive outcomes will always be supported. The key question policymakers ask are, is it feasible? Is it cost effective? Does it add value without draining existing services? If yes, the government will find a way to adopt it. And this is also another one from the government official saying that if we invest in youth mental health, we reduce the risky behaviors, HIV transmission, substance use, violence, we protect their cognitive development and resilience. Otherwise, the consequences of early onset disease, loss of workforce potential, high treatment costs will be much greater. In conclusion, therefore, the providers, that is the inner settings, and the government officials who are the outer settings, reported strong acceptability and appropriateness and feasibility of the intervention, and both groups stressed that the government endorsement and financial support is needed for sustainability. So we have a very big list of acknowledgement for the implementation of Sauti ya Vijana. So we have a list of the project managers, the data managers, and everyone. Thank you, everyone, and also the special thanks to the youth who participated in Sauti ya Vijana. This is the photo of the refresher course in January last year. This is a group of the peers, supervisor, group leaders, and the other people for Sauti ya Vijana. Thanks for listening.
Asante sana. Please another round of applause for all the presenters. Asante sana. So because of time, we're going to move through to the next session, which is our panel. And then we'll keep all our questions in the end. Probably some of them will be answered during the panel discussions. We don't know. And if not, then you'll ask at the end. So may I please call upon the first, Dr. Lillian Combat, to take the stage. She's a pediatrician and public health expert. She's also the
years, as well as the work you have been doing and the knowledge shared within this community. So I'm honored to be given this opportunity to give you this award, which including the certificate, but as well as the trophy for the work you have done. So congratulations and keep it up. Thank you. And John? Yes, and Prof wants to say an appreciation word. Karibu.
So I'm a bit overwhelmed about this. So maybe on behalf of myself and my colleagues, my researchers, my co-PI, my consultants, as well as all the rest of the team, we give our great appreciation to THS for considering the award. Professor Blandina, thank you so much for being the one to to hand it over. Yeah.
So, thank you very much. On another note, please don't leave this meeting, because we continue with the adolescent sessions, and now we are also continuing to discuss mental health in adolescent and youth. Please stay with us. Madam Gertrude.